Hello and good day, everyone. So today I will be talking about fall prevention and health education, which is part of international patient safety goals, which we are implementing in our department. And so for today, we will be tackling the different objectives for this lecture. First is to maintain patient safety. Second, to reduce the risk of injury. Third, to determine the way of the fall's occurrence. Fourth, to know how to fill out the fall assessment form. Fifth, to know how to fill out the health education and acknowledgement form. And lastly, to identify strategies in formulating health education. So, definition for fall. So, when you talk about fall, it has something to do with unexpected falling down from high position to lower position, with or without injury due to physical or mental effect. In our institution, we do have certain incidents of fall, and we want this to be prevented, making it sure that all nurses will be able to comply as to how we can assess patients who are at risk for fall. Second is near fall. For the definition for this is the sudden loss of balance with incomplete fall, which includes slips, stumbles, or strip with ability to control. So when you talk about fall, it's not necessarily mean that we are considering the patients alone, but we are also considering your colleagues, yourself, or whoever is inside the institution who might be at risk for fall or some injuries. So there are different causes of fall, and one of which is the individual, which the following criteria would include the loss of consciousness. Second is orthopedic disorder such as your fracture, hypoglycemia, which is the decrease of your blood glucose level, anemia or vision loss, hypotension for those who have very low BP or those who are below the normal level, drug action, particularly the side effects and the adverse effects of the medication or untoward effects of it. Another thing is post-operative, which includes your sedation, those who are under anesthesia, aging and sleeping habits, those geriatric patients that we have who are admitted in the hospital, and those who have conditions such as paralysis, TIA, and your CVA. Environmental factors would somehow include first is unsafe higher positions. So this can be included as to how we level, particularly our beds in the rooms, those bed rails that aren't raised or that aren't secured, unlocked wheelchair when we try to transport our patient, or even the stretcher, water in front of the floor, wire connections, steps or stairs, walker, and interfering clothes to our patient, or even to some of us in the institution. And patient fall injury has different levels. So first, when you say no injury, we'll consider it as there is no really injury that is happening. And when we talk about minor, it has something to do with minor injury with abrasion or bruise treated by dressing, limb elevation, and topical medication. And when we talk about moderate, it has something to do with the injury leading to suturing or limping, treated by bandage, splinting, muscle, or point strain. And when we are talking about major, it has something to do that leads for casting, skin traction and surgery, mainly neurological and vascular attention. And worst is death. That means to say that patients died as a result of serious injury. And UTD has something to do with unable to determine from the documentation or from during investigation. So all inpatients will be assessed for the risk for fall upon admission. So when the patient comes in inside the emergency room, the nurse should have a critical eye in terms of assessment and making it sure that there is a reassessment which is being indicated for all the following conditions. So first is post-operative. Second is following procedural sedation. Next is following administration of medication after certain blood transfusion that is being conducted, and even transferring patients between two units from one unit to the other. And another is recording incident for fall, any changing in ambulatory status or elimination status. And at the same time, we also have to apply certain risk fall procedure for our patient. And this includes the fall risk assessment form that I will be teaching you how to utilize it later on, the fall signages that are applicable in our institution, fall labels in chart. As we know, if our patient is risk for fall, we do have this green tag that we are placing in the chart as part or an indicator for us nurses to know that this patient is at risk for fall. And even the signage that we are going to place at the bedside of the patient in terms of high risk or moderate risk for fall. With regard to that, we also have to do with the reporting and documenting any fall occurrence. So if there is a patient who is experiencing fall, then we need to make sure that there is a documentation that we are doing. A letter should be submitted to the nursing service department so that we can do investigation as to how we can manage or give attention to the patient who experienced such fall. And all falls patient should be classified according to the level of injury. So this is a very good example of an adult fall risk assessment. So this is actually new to our department in which we are anchoring this particular form from other Mount Grace Hospital nursing service department. So since this is a very good practice that they're already practicing in their institution, we might as well adopt it so that we have to make sure that all patients who are at risk for fall or those admitted patients in our institution are well assessed and taken good care of by our nursing personnel. So I'll be dividing the form into two different parts so that it's easier for us to see and to magnify such content of the form. So here, as you can see in the upper portion, we have to make sure that we can fill out the specific information that is related to our patient, particularly in the upper corner. And when you come in into the full risk assessment part, first is you have to provide the date that you're going to assess the patient. Usually this is a responsibility of the charge nurse when they do refill of the chart. And it is being divided into 6 different dates already. So it's not really consuming enough space or paper for our chart. So in the first part, you can see here the Morse form. So it has 6 different categories, which includes history of fall, secondary diagnosis, ambulatory aid, IV therapy or heparin lock that is attached to the patient, the gait of the patient, and even the mental status. So the next column says here, yes or no. Okay. So the second thing follows with secondary diagnosis, ambulatory aid has to have furniture, crutches, cane walker, followed by none or bed rest or nurse assist. IV therapy lock comes with a yes or no option. Gait comes with impaired. Next is weak. Next is normal bed rest or wheelchair. And lastly, the mental status comes with um, overestimates, forgets, limitation oriented to own ability, which is the last one. As you can see in the third column, there are different numbers that you can see. So this is the grading. So when you say yes for a history of fall, that makes it 25 points added to that particular criteria. And when you say no, it means that it's 0 and you have nothing to add into the criteria. Next is the secondary diagnosis. When you say yes, it comes along with a score of 15. And if it's no, that means to say that there is nothing, no, that should be added. And when you talk about secondary diagnosis, these are diagnoses that are being identified by our medical doctors, physician, or even RODs or resident on duty in terms of their medical condition or status. Next is the ambulatory aid. So if the patient uses furniture, what does it mean? You use furniture such as the chair or even the tables when the patient walk inside the room, no, in terms of assistance, but they do not have any cane, walker, or crutches at all. So they tend to lean into the furniture, particularly the chair or even the side tables that we have inside the room. So that makes it 30 points additional if you can somehow assess patients who are utilizing furniture. And when our patient does have crutches, cane, or walker, we can add 15 into the total score. And if there are non-ambulatory aid needed, then that means it's 0. Another thing, if our patient has an attachment of an IV fluid or an IV line or even a hep lock, when they do have that one, it is automatically considered 20 points add-on. That means to say 0 if it doesn't have any or without IVF. And when you talk about the gait of the patient, when you talk about being impaired, as you notice, no, if you do your assessment with your patient or even you see your patient walking inside the room, no, or getting up out in her bed or his bed and walking inside the room, when you see that the gait is impaired and out of balance, we can somehow consider that as an add-on 20 points to the scoring. And when you say weak, your patient couldn't really ambulate, but still tends to manage to be out on her bed, but really needs certain assistance. However, limbs are somehow weak, that can be considered as 10. And without um, any unusualities in terms of the gait of the patient, that is considered as 0. And when you talk about mental status, it has something to do with overestimates or forgets limitation. So we can come up with 15 points for that. And if patient is somehow oriented to own ability, that goes along with a no point at all that is being added. So let's take a very good example. On the next column, you can see here AM, PM, and night, right? And the shifts is our shift in our institution is being divided into three different shifts. So say, for example, I'm on a morning shift. So I'm trying to assess a particular patient who is oriented with Glasgow Coma scale of 15, verbally converse, oriented, and could follow commands. However, my patient has an IV line, doesn't have any crutches at all, doesn't have any history for fall, doesn't have any secondary diagnosis, but the diagnosis is more into dengue fever. Okay. And ambulatory aid, nothing to worry about because there are none. And the gait is really good. There are no problem in terms of the balance of the patient, and the mental status is really good as well. It's GCS 15, no? So let's try to consider that. So when you talk about assessing the patient, first is you have to take note of the history of fall. Of course, you really have to ask the patient if they were able to experience such fall, not just in our institution, but as well as in their work, in order for you to come up with a very good interaction with the patient and could ask probing questions that would lead to a very good assessment. So when you talk about the history of fall and if the patient doesn't have any, so you have to write there 0. Okay. Secondary diagnosis, nothing to worry about because there are no diagnoses or diagnoses at all, which are add-on. So let's score it with a 0. So out of 1 and 2, we have a score of 0, nothing to worry about. Now with ambulatory aid, you don't see patient walking with an assistive device or leaning into furnitures and somehow could really ambulate well, no? And that makes it a score of 0. So criteria 1, criteria 2, and criteria 3 are all 0. Now, since patients have an IV line of plain and necessity, for example, of 30 drops per minute hook at the right arm, then we can somehow consider it with 20. No, we add on 20 to the one that you are trying to add. And next is the gait. The gait is balanced. Patient can really walk well without any assistance. That comes along with a 0 score. So out of 1, 2, 3, 4, 5 criteria, only IV therapy and heparin lock says yes. And that comes with a 20. And with a mental status GCS 15, nothing to worry about. Very oriented, comes along with 0. Okay. So out of all that I've mentioned, it seems like that our total is 20. Now take a look in the next row next to mental status or number 6, no mental status. It says here take note, if it's lesser than 25, you consider it as low risk. If it's 25 to 44, it's a moderate risk. And if it's greater than or equal to 45, it's high risk. Now the total of my scoring is just 20. Then therefore, I categorize my patient as low risk. Okay? Next, you have to take note that we have to make sure to implement standard intervention for low to moderate risk scores. At the same time, we also have to implement both standard and high risk interventions for high risk scores. So what am I talking about in this particular part? No? So I'll go to the next page for you to be familiarized with. No? So first things first is the fall preventive measures. As you can see, that is actually in the next half of the sheet. No, by the way, guys, this is just a one sheet of paper. No, that is being inserted into the chart. But here I'm just trying to divide it into two so that it would be magnified. Okay, so if your patient is at low risk, moderate risk, or high risk, you have to make sure to fill out the standard interventions. Standard interventions has something to do with a different criteria. No, as you can see, first criteria is to educate patient or significant others regarding fall prevention. And what are we going to do on that? No, you can see that there is a box to the next column. Let's say in my AM shift, no, I was able to educate patient or significant others regarding fall prevention, knowing that my patient belongs to a low risk for fall. No, low risk, then again, moderate risk and high risk comes along with the standard interventions. Everyone should comply with this particular part or criteria in checking your particular column for your respective shifts. So in AM, I'm going to check it, since I was able to educate my patient. And then familiarize the patient with the environment. I was able to educate the patient with the environment inside the room. Then I gotta put on check mark. Now have the patient demonstrate call bell use. When you talk about call bell use, since it is not functional in our rooms, we can somehow consider the significant other to go to the nursing station, no, in order for them to refer accordingly what assistance that they need to have in order for them to avoid certain fall. Then we can somehow check it. Next is maintain call light within range. Same thing as with our demonstrated values, no? Maintaining call light within reach can also be checked as well. Let me just also insert this one in my discussion in terms of the call bell and call lights within range. Our maintenance is already working their best in order for it to work and in order for it to function again. No? So this has already been worked on and it's already been reported, by the way. Next, we have to place bed in low position when the patient is resting in bed. Raise bed to a comfortable height when the patient is transferring out of bed. So when you do that, you have to check it and then keep hospital bed breaks locked. Of course, you have to lock the break that is in the lower part or in the bottom part of the bed. And if you did that, you have to check it. Okay. Keep wheelchair or wheel locked when stationary. No, so if your patient doesn't need any wheelchair, no, nothing to worry about. No, you just have to place a check mark, making it sure that you follow certain standard interventions at all times. Next is keep patient care areas uncluttered, making sure that the environment is free from other objects. Another thing is you instruct patient to raise side rails when lying on bed. You can do this one, or even the patient as well, or even the significant other can do that. You just have to educate the patient about it and also the significant other how to raise it. Then you put a check mark. Check walking aids are in reach if it's being used, such as your walker or cane. Next is instruct patient to use handrails, bathroom, showers, and hallway as necessary. So as you can see inside the bathroom, we do have handrails, no, provided to our patient to avoid falls. So if you're able to educate that to our patient in terms of standard intervention, you can place check. And we assess patient's ambulation status every shift if applicable. So this is not just in the AM shift, but particularly in PM and night shift. As you can see, guys, this will not just be considered if the patient is at the ER. But once the patient is being transported to the ward, we have to continuously do this assessment at all times to prevent fall from or injuries from our patient. Now let's go to the next part. No, so when you talk about high risk, if your patient has a high risk score, no, noting that high risk, it says here that it's greater than or equal to 45, considered to be high risk. Say, for example, there's a history for fall, that there's a secondary diagnosis, particularly a critically ill patient who is in the ICU. Ambulatory aid, particularly furniture, it's because they are on GCS free. IV, they do have it. The gait is really impaired at the same time, the mental status, which falls to a glaucoma scale score of 3, then therefore we can consider our patient who is at high risk. So say for example, patient is in high risk, no? You have to include this in your checking, no? So include posting of fall risk signages, no? You have to include that at the bedside. You have to check it as well. No, by the way, guys, for the posting of fall risk signages, I've already coordinated this one to the marketing team, and Miss Rice is already doing her layout, making it sure that it is well approved by Mount Grace as well. So once it is done, we will be procuring certain copies, and we will be replicating copies for all the floors. Next is instruct patient and relatives to call for assistance prior to ambulating if necessary. So you always have to include the significant others and also other people who are at the bedside of the patient, who are there to assist the patient, to be part of the care. Turn on night light at bedtime, making sure that they are being instructed to turn it on while they're asleep. Keep the patient personal possession with patient safe reach at all times, utilizing the side tables perhaps. Then interact with patient to see the personal needs are all met. Instruct patients and relative on medication that is the predisposed patient to fall, such as your benzodiazepines, diuretics, laxatives, anticholinergic, opioids, antidepressants, and neuroleptics. So if your patient is taking those kind of drugs, I have to consider, include that in your health teaching at the same time, giving idea to the significant other and even to the patient, if the patient can somehow still understand what you're talking about, so that they're aware as to what are the adverse and side effects that they might be able to feel after taking such medication. So say for example, everything was all done by the nurse, then you're going to provide your initial. Usually in our hospital, we do the shortened signatory that we do have. And at the bottom part of the page has something to do with the department or unit that you're being assigned. Your complete name, you can use your stamp or throw dot, your initial as well. Okay. So it's very important that you have to affix your initial so that we'll be able to know that you're the one taking good care of that kind of patient, particularly if it is in the low risk, moderate risk, and high risk. All right, I think that ends there in terms of how to fill out the risk for fall assessment form. And now I will be going to the second part of my discussion, which talks about the post-fall protocol of care in our institution. So first, we have to implement the following interventions after any fall. So first things first is we do first aid. We are in the hospital. We have all the materials and equipments needed for us to respond to first aid. We also have to ensure that patient is safe from further danger, and we have to ask help from the significant other or to your colleague who is your partner, or even the charge nurse perhaps. We can also tap the clerks, the PGI, or even the resident on duty if they are there or present. And please do not reposition your patient until the patient is ready to do so, because we have to suspect that there might be some fractures or major injuries that happen to our patient. We might move our patient, which would somehow lead to further injuries in that kind of scenario. You try to move the patient safely with attention to moving and handling, and there should be proper reporting, proper documentation. The nurse supervisor should be heads up in terms of the incident of fall so that we can make a report. And we can somehow also investigate as to what really happened in that particular shift or in that particular event or phenomena. And also patient and family education should be always be important, and you have to educate them at all times, okay? And emphasizing certain interventions to avoid such fall again. There are also standard fall precaution for low risk patient. We do have the first thing that we have to consider is to orient the surrounding environment of our patient. Once the patient, by the way, comes in our institution, we have to make sure that the surrounding environment should be well presented to the patient, and they are being discussed in accordance to the placement that they are being placed either in the wards or in the private room or even in the semi-private room. You also have to provide medication information. It's very important, as I mentioned it before. Adverse effects and side effects are important to be discussed to them in order for them to be aware. You also have to conduct regular environmental rounds in all areas surrounding the patient to decrease the risk for fall. You have to instruct patient to call for assistance if they need so. And if they are unsure of what they're doing, we have to respond. Instruct to the use of rubber, soled shoes, or non-slip footwear to prevent slipping. At the same time, those particular footwear that would not impede their agility. Next is secure call bell, phone, or bed table as much as possible, or the side table if necessary. Ensure the clothes are not interfere with the patient's mobility at the same time. Maintain the bed in the lowest position and ensure bed and wheelchair are locked. Keep bathroom light on and the floor dry, and put side rails up at all times. So standard fall precaution for moderate risk patient. You have to identify all fall risk on medical record and include in the shift endorsement. You really have to include it in the endorsement, emphasizing that the patient is on a category of a moderate risk for fall. Assist and supervise ambulation as much as possible. Reinforce to always call for assistance. Conduct hourly safety checks. You go to your patient's bed or room at all times. You also have to perform regular pain assessment if your patient is feeling pain or in pain. Offer assistance to the bathroom or use bedpan hourly while awake. And don't lower the bedside rails if any nurse rise it up. Next is evaluate for reversible causes. See, for example, orthostatic blood pressure, monitoring of blood sugar, adequate hydration, check the patient after visitors leave always. And you also have to consider patient education, family education, and apply fall risk handband. So this one we're already working it out. Now we are trying to consider a yellow band for risk for fall patients, but it seems that our purchaser wasn't able to procure it yet. But right now we are cascading more into the signages such as the fall prevention signages that is being seen in the bedside of the patient. At the same time, the chart of the patient should be well properly labeled with a green colored cartolina for us to know that the patient is at risk for fall. So for high-risk patient, we have to apply all low and moderate interventions as much as possible. We have to place a high risk for fall sticker label on the patient's chart and patient's room, as I mentioned earlier. Raise both upper and lower side rails. Place mattress on the floor if necessary, if they can procure any. But in our hospital, we do not have any mattress being provided. But if the patient and the significant others are well coordinated with health education, to provide certain mattress on the floor, that would be perfect. Review the medication, assess the need for physical therapy consultation if needed, and assess the need for one-on-one monitoring as needed, particularly those patients who are critical. So patient and family education, we have to make sure that we can educate both the risk of falling, safety issues, and their mobility limitations. We also have to teach the patient to make positions that they should change slowly, and at the same time emphasize how important the family is involved in patient safety, because in our institution we are more into collaborative action with them, knowing that we are too busy within our shifts. And I know that it's really hard for us to really monitor, particularly those who are assigned at the ward. So thus we have to involve the significant other or the family inside the room. And lastly, we have to emphasize what patient can do to be healthy, active, and independent. All right. So let's go to health education, no? So I'm trying to relate health education together with this particular discussion. It's because it's a continuation, and this is would be a very good agenda to know an idea as to how important it is to health educate our patient, the significant others, or even the family members of the patient in relation to fall. However, we are not focusing more into fall, by the way, for health education. This can be in general form. This can be included through medication in terms of health education, environment, treatment, health teachings, outpatient follow-up, if any, during discharge, the diet of the patient, even spiritual, social, and even the sexual parts of our patient. So the aim and objective of health education first is to encourage staff nurses to adopt and sustain health promoting lifestyle and practices for our patient. We also have to promote interest, provide new knowledge, improve skills, and change attitude in making reaction decision to solve their own problem. So as nurses, we have to be an advocate to our patients, making it sure that the only thing that we can help them to become self-reliant is to help educate them. I always believe that while our patients are inside our hospital, we nurses should always provide the proper medical treatment as being ordered by the physician. And our patient we also have a big role in terms of helping our patient understand their own conditions and even the treatments which are going on. So, nurses' role in health education first is to provide an opportunity for patients to learn how to identify and analyze health related problems and how to set their own targets and priorities. Another thing is that we indicate the patient's alternative solutions for solving the identified health and health related problems, and we nurses make health related information easily accessible to our patient. Always make sure that our hospital, SW Med, it's no longer just a place now we are caring for our patients, but it can be seen as an independent healthcare center for the community in which we have a higher responsibility of providing health education to them where they're at in our institution or while they're in our care. So, I mean, a certain method which is applicable in health communication would be the individual approach. In the hospital, the health education must first create an atmosphere that is welcoming and allow patient to talk as much as possible. In this individual teaching, we can discuss, agree, and persuade the patient to change his or her behavior while inside the hospital. So if we nurses would somehow promote, we need to organize, we need to implement and even evaluate health education activities. This could have been a meaningful term or a long term, which can somehow influence on the behavior of our patient. The individual approach is important as we communicate directly to our patient, changing their behavior and at the same time involving their relatives in improving their health. And I also believe, no, na in our institution, we therefore have this particular potential or the role in promoting patients' health and in promoting health education programs that includes preventive strategies. This would somehow this would maybe a great time for us nurses to empower patients to increase their knowledge, skills, and even enhance their attitudes toward best practices. So here, um, this is the health education acknowledgement form. Every day you are going to fill this out in your shift. No, it's not just once, but every day on your shift. Yes, you heard me right. No, there might be a lot of forms that will be introduced in our department, but we are trying to inject it one by one in order for us to adopt it in our daily routine. And somehow health education partakes already once it is being cascaded and once you have seen the video. So as you can see in the upper portion, the title, by the way, is Health Education Acknowledgement Form. Okay, and you have to fill this out every shift, no, or every day that you will be having your duty. So say for example, okay, but by the way, first things first, you have to fill out all the information that you can see in the upper portion. All those information should be filled out, making sure that the form is completely labeled. And the next column would be, the next table would be, comes with the date. I believe that that is the particular date that you're on duty. You also have to use color coding. By the way, for the fall risk assessment form, you have to use proper color coding of the bulb and together with the health education acknowledgement form. So in the health education form, or health education column, what is included in there, no, particularly the medications, environment, treatment, your health teaching to your patient, diet, spiritual, social, and sexual activity can also be part of our health education to our patient. Okay, so when you talk about health education, it comes along first with a verb. The first part of your construction of your sentence should be with a verb. It can be in a bullet form, not totally narrative compared to your after, which is narrative. No, so you can somehow do it in bullet form if you want to. And then once you have all the health education that you are providing to your patient, no? By the way, guys, you would be asking how many health education that you're going to include there, no? It's up to you for as long as it's applicable or for as long as you were able to do that to your patient. And another question you might be able to raise, how about my patients who are may go home, sir? Are we going to include health education for them? The answer there is yes. We have to include an entry for health education even though the patient is still in or for may go home or even instructed with their medications already. Sir, how about for the discharge plan? They're already been instructed with certain health education and instruction. Are we going to include health education acknowledgement form to be filled out? The answer there is yes. You still have to consider health education acknowledgement form since they are still in and they are still in our care. Okay, so after which you're able to identify or enumerate your health education, you can somehow provide your complete name with your stamp using your stamp or your true dat and then sign. And the acknowledged by is from your patient or from the significant others whom you're able to have certain health education. Now, certain health education that you're able to provide. Okay, so that it's easy as that, no, in terms of how you're going to fill out the form. Okay, don't forget you have to make sure that you complete the form at the end of your shift. Okay, so the nurse's significance of health education. For us to be effective health educators, nurses need skills in planning and implementing attractive and effective plan to patients. So when you plan with your patient, you have to collaborate with them and you have to make sure that you can come up with a very good health education, which is suited in their situation or in their current situation. And they also need to develop, we nurses also need to develop skills in evaluating the effectiveness of their effort to emphasize the impact of their teachings. So in order for us to implement what we need for our patient or what our patient needs, we have to make sure that we can somehow emphasize health teaching and health education in order for them to instill it in their minds, know that they're able to understand what we are doing. At the same time, they are part of our care, making sure that we are considering our patient in whatever things that we do to them. All right, I think my discussion ends there. Thank you very much for listening. If you guys have any questions or if you have some clarifications, feel free to approach me or any supervisor or even your head nurses in terms of filling out those two forms that I introduced. Once again, have a great day and thank you very much.